All right, let's jump right into this explainer. Today we're going to completely master the classification of anti-cancer drugs. Now, I know that sounds intimidating, but even if you are a complete beginner starting from scratch, by the end of this, you're going to understand modern oncology inside and out. We're going to use a few incredibly simple, really powerful mnemonics to lock it all in. But to really get where we are today, we first have to talk about a massive, industry-wide paradigm shift happening across all of pharmacology.
To understand cancer drugs, we actually need to look at an entirely different field first: asthma. If you look at the 2026 GINA asthma guidelines, they show this undeniable, massive shift. For decades, medicine basically relied on broad chemical shotgun treatments. Older therapies that just hit healthy and sick cells indiscriminately, causing a ton of toxicity. But right now, we are moving incredibly fast toward a sniper approach. We're talking precision medicine, driven by specific biomarkers that targets exact cellular pathways while leaving the rest of your body completely alone.
And honestly, the asthma field perfectly nails why this shift is absolutely crucial. For years, relying on those old shotgun short-acting beta agonists ended up causing excessive glycolysis and even life-threatening lactic acidosis. It was just too toxic. Because of that overwhelming collateral damage, medicine has rapidly pivoted toward hyper-targeted biological snipers that are customized to patient biomarkers. Take a drug like depemokimab. It precisely hunts down interleukin-5 and just ignores the rest of your immune system entirely.
So, why bring up asthma? Because this exact same evolution, from a chemical shotgun to a biological sniper, is literally the best way to wrap your head around our main focus today: anti-cancer drugs. By understanding this one big shift, the massive, super complex world of oncology suddenly becomes incredibly easy to organize in your mind.
Okay, here is the master study tool that's going to map out this whole topic for you. Just remember the mnemonic CHAP. That's C for cytotoxics, H for hormones, A for antibodies, and P for protein kinase inhibitors. We'll walk through each one of these, and then we'll wrap things up by looking at some wild oncology breakthroughs for 2026.
Let's start right at the beginning with the C in CHAP: cytotoxic drugs. These are your old-school, conventional chemical shotguns.
The main thing you got to remember here is that cytotoxic drugs are not smart. They literally act on all rapidly dividing cells in the human body. They rely on this terrifyingly small margin of selectivity. Basically, the entire goal is to try and kill the fast-dividing cancer cells just slightly quicker than you cause unbearable, catastrophic damage to the host's normal rapidly dividing cells.
Now, to easily memorize these traditional shotgun chemotherapies, we've got a second awesome mnemonic for you: the 4 A's. First, you have alkylating agents, like cisplatin, which literally form covalent bonds to cross-link and break DNA. Second, antimetabolites, like methotrexate. These act like fake building blocks to totally subvert DNA synthesis. Third, cytotoxic antibiotics, like doxorubicin, which actually come from microbes. And fourth, agricultural or plant derivatives.
Let's actually zoom in on that last group for a second, because it's kind of mind-blowing how many of these hardcore cytotoxic drugs come straight from nature. Vincristine, that's derived from the Madagascar periwinkle. Paclitaxel, that comes right out of the bark of the Pacific yew tree. These agricultural derivatives basically poison the cell's physical machinery. They halt or freeze the microtubules, so the cell is just physically trapped and unable to pull itself apart to divide.
But because of that shotgun effect we talked about, the collateral damage is just brutal. Have you ever wondered why standard chemo makes your hair fall out? It's because hair follicles are made of rapidly dividing normal cells. Why does it cause extreme nausea, oral sores, or severe infection risks? Because the lining of your gastrointestinal tract and your bone marrow are also constantly dividing. The shotgun just hits them all.
And as you'll see noted in standard pharmacology texts like Ring and Dale's, this overwhelming toxicity is exactly why researchers realized they had to find a better way. We desperately needed a way to attack the defective controls of a cancer cell without basically nuking the healthy cells around it.
Which perfectly bridges us to the H in our CHAP mnemonic: hormone antagonists. Think of these as the historical stepping stone from those broad shotguns to true precision.
See, some cancers actually rely on your body's natural hormones as fuel to grow. For example, certain breast tumors use estrogen to thrive, and prostate tumors use testosterone. So instead of using a shotgun to destroy all dividing cells, we can use hormone antagonists, drugs like tamoxifen for breast cancer or flutamide for prostate cancer. These drugs specifically block those receptors, effectively starving the tumor of its fuel, without causing that massive systemic destruction of the 4 A's. The exact same logic applies to using glucocorticoids to shut down lymphocyte proliferation in lymphomas. It's all about cutting off the specific growth pathway.
Okay, now for the really exciting stuff. We are moving to the A and P of CHAP. These are our biopharmaceuticals, the ultimate targeted snipers.
First up, the A stands for monoclonal antibodies. Now, these aren't just simple chemicals, they are massive, lab-created proteins that act like highly sophisticated homing missiles. They literally patrol the bloodstream until they find a very specific mutation or receptor that only exists on the cancer cells. Then, they bind them to either block their growth factors or flag them so your body's own immune system knows to swoop in and destroy them.
This is precision medicine in action, and it is amazing. Take bevacizumab, for instance. Tumors are greedy. They need their own blood supply to grow, so they release a factor called VEGF to sprout new blood vessels. Well, bevacizumab acts as a sniper that neutralizes VEGF. It literally starves the tumor by cutting off its blood supply. Or look at trastuzumab. It specifically hunts down the HER2 receptor, which is a mutation found in about 25% of breast cancers, stopping the tumor's growth signaling dead in its tracks.
Next, we've got the P in CHAP, protein kinase inhibitors. If antibodies are fighting on the outside of the cell, kinase inhibitors are the special ops sneaking inside the cell. They are small molecules that penetrate the cell membrane, find the specific mutated enzymes, the kinases, that are screaming at the cell to multiply, and they just bind to them and cut the communication wires entirely.
Now listen, if you only memorize one single drug from this entire explainer, make it imatinib. It's universally hailed in pharmacology as an absolute conceptual masterpiece. Imatinib is a kinase inhibitor that zeroes in on a very specific mutation called the BCR/ABL kinase. You might know it as the Philadelphia chromosome, which causes chronic myeloid leukemia. It targets this unique genetic error with such pinpoint accuracy that it completely transformed the survival rates for what used to be a devastating disease, and it does it with a fraction of the side effects of traditional chemo.
Finally, let's see how all of this builds into the absolute bleeding-edge breakthroughs happening right now in the 2025 and 2026 regulatory landscape.
Because the entire industry has aggressively shifted away from those old cytotoxics. Almost everything getting approved right now is hyper-targeted. We're talking antibodies, hormone antagonists, and rapid injectables. For example, look at datopatamab in early 2026. It's an antibody-drug conjugate for lung cancer. What that means is it uses an antibody to sniff out the cancer cell and then delivers a payload, a tiny microdose of a drug directly inside it. And the pipeline is just packed. We're seeing zolbetuximab for specific GI cancers, super fast injectables like Tecentriq, and precisely targeted treatments like vepdegestrant for breast cancer. It's an era of pure precision.
So what is the big takeaway here? Well, the future of cancer treatment is entirely custom-built for you. We are rapidly moving toward a reality where doctors can take a simple blood draw, sequence your exact tumor DNA using circulating tumor DNA, and then deploy a custom biological sniper. We can even edit your own immune cells using CRISPR to create CAR-T living drugs that are specifically programmed to hunt down your unique cancer. The science here is just undeniably incredible.
Which leaves us with a pretty massive question to close on. We've gone from the devastating collateral damage of the 4 A's all the way to the incredible pinpoint precision of CHAP's biological snipers. As these hyper-targeted, biomarker-driven therapies become faster, better, and cheaper, are we finally witnessing the last days of the toxic chemical shotgun? It is an absolutely thrilling time for medical science, and I hope this classification makes it all a lot clearer for you to learn and remember. Keep diving in, keep learning, and I'll catch you in the next explainer.